Now it's the Joe and Peter show, starring Peter. And I personally have been looking forward to this talk about obesity because I myself have a thing for ice cream. And I was thinking that one day, perhaps if I continue eating at the rate I have, I'll be a customer for something you invented.
Well, that could be, but unfortunately, most of the surgeries and other treatments for obesity can be defeated by ice cream.
That's funny.
Because at the end of the day, it's a zero-sum game. Calories in equals pounds on.
Yeah. I'm not going to bash exercise. I actually started doing it this year. And then I'd be going to the gym every day, I'm sure, but COVID, so.
Yeah.
But I've always found for my body anyhow that exercise and weight are not correlated. And sometimes you even hear, oh, well, now it's muscle, so that's why I'm heavier. But I don't personally see pounds come off by sweat. It's by calories in or not.
Yeah. Well, everybody's different, of course, but in my observation, and I think this is borne out by published papers, the kind of exercise that most dramatically reduces weight is aerobic exercise. If you go to the gym and roll some iron around, it uses actually very little calories because it just doesn't use much. On the other hand, if you spend the same 45 minutes or an hour on a treadmill working up a sweat, and you actually sweat, that can dramatically reduce your weight if that's what you want to do.
Okay, well, I know that's a topic for another day.
Yeah.
What'd you invent?
So I invented a surgical method and an enabling tool that goes with the method. And I do have a slide presentation and a video that explains it quite readily.
Neat.
But just very briefly, if the stomach is, let's see.
What year was this invention?
2012.
Oh, okay.
Yeah.
But I expected you to say something in the 1900s because when we spoke, gave me an impression that it was like the beginning of this particular thing. And I thought that lap bands and the like were around for decades, no?
Oh, that's true. Yeah. There's been other surgeries around, and I'll show you some pictures of the other surgeries. I call them legacy surgeries because that's where they belong. And they've been around for a long time. And they all have severe disadvantages, a very, very low value proposition for the patient. And that's why the adoption rate of surgery amongst the obese patient population is less than 1%. And it's been less than 1% forever. And there's no signs that it's ever going to even top 1%. It's an absolute, utter failure of the medical system in treating obesity.
Okay.
So I saw this, sorry.
No, go right ahead. And I'm wondering if you want to switch and show us your slide or.
Yeah, sure, right now. Actually, it'll facilitate the whole discussion because it'll just make things go quicker.
All right.
So if I hit screen share.
Should work, just as we practiced yesterday.
There it is.
And
there we go.
Well done. Well done.
Okay, so I always look for an opportunity to find this slide, to show this slide, because the thought that I express here is valid for just about any medical device or any effort that us guys get into. No matter how much fun you're having, you really must be outcome driven. Otherwise, you just end up in the sailboat on the left, which is not going to get you anywhere. You really want to be in the sailboat on the right and being outcome driven. And I really like that picture because that's not my boat and that's not me in the picture, but I was in that sailboat race, and it was a lot of fun. Separately, if anybody wants to talk about sailboat racing, I'm in.
All right. Noted, it won't be me, as I am not seaworthy. That's a story for another time, I suspect.
Yeah. So let me see if I can advance this. Yeah. I like to show some of my own background because one of the first things that people ask me is, well, are you a doctor? And I say, well, no, I'm not. I've got an engineering background and sales and marketing. They say, well, how can you invent something like this? Well, I did. And my flippant response to, are you a doctor, is that if I were a doctor, I would have invented something that's very similar to one of the legacy procedures that has shown itself to work. And so my situation right now is that, having sold the 9, and full disclosure here, my 9 founding patents on this procedure and on the device, I have sold, and so I no longer have any financial interest in it. It's being developed elsewhere, and so I'm interested in, just because I've been in the medical device arena for my entire career, I have a lot of interest and skills in the area, and I'd like to find something else to do to occupy my time.
Okay, well, impress us, and somebody on the call might be like, hey, Peter, you can help me.
Yeah.
It all rides on this presentation, Peter. No pressure. You've been in high pressure situations before. Like that boat race.
Say again, I missed that.
Like your sailboat race.
Yeah, sure. Pressure is good. I enjoy it. I enjoy the creativity and the pressure of the medical device business.
All right, don't mess this up.
So yeah, something else that's interesting that happened that was quite a benefit to me was that at the time that I invented the procedure, it was coincidentally, and this happens sometimes in the invention business, as you guys will know, someone else invented basically the same thing. His name is Dr. Talapur out of Tehran, and I disclosed that when I discovered that, I disclosed it to the patent office. They took a good, long, hard look at it, and they decided that there was no interference by him on my invention. And so they went ahead.
He came first? Concurrently. So you believe it really was the same time? There wasn't a...
Yeah, it was, just
okay.
at the same time. Because we were addressing the same need in the Iranian medical arena. He saw exactly the same need with a million or two, I don't know how many millions of overweight people that had no hope of access to their medical system. And so, being a good doctor, he set about finding a treatment for these obese Iranian people. And he came up with the only feasible, logical solution that would work surgically, and that's exactly the same path that I followed. I came into the obesity arena tangentially, and I knew nothing about it before I came into it. But when I saw it, I thought, geez, this is a huge opportunity to help people and to develop a business. And so that took us down the same path, and we invented the same procedure. Nevertheless, the patent office decided that that mine was functionally essentially first, I guess, and so they awarded me the patents, and so that's what happened.
And so he doesn't have equivalent patents that he can use or something like that?
Does he have equivalent
patents I don't know how it works. I mean, since you both showed up at the same time, did you win and he lost, or did
No,
you both
no, there was no win and loss because functions in the European under the European patent
I
area,
see.
and my patents are US patents only. And that was a strategic decision, by the way, because myself and my founding partner, we did not have the funds, many tens of thousands of dollars per country to go patenting all around the world, or even in the major countries like Japan and China and South Korea. So the patents that I have or had were for the US only.
Okay.
Did that answer your question?
You did. And I'm just pinging Stephen Carter, who's a European IP lawyer. I thought he'd be interested in this call.
Yeah.
I want to see.
Turn up the volume here. Yeah.
Do you have a picture of what a laparoscopic gastrification looks like?
Yes, I do indeed. I'm just getting back to it now. Yeah. So before I show you the picture, and the video is coming up next, by the way, the addressable market that I discovered was so big and so unaddressed that I had almost an amusing difficulty when I started working on a business plan, that the numbers came out so big that they were simply phantasmagorically unbelievable because of the large number of obese people worldwide. I had to keep on trimming down my numbers, which is a little different to other business plans that I've worked on in the past, where you keep on looking for some sort of fudge factor that you can maybe increase your numbers a little to try to attract some interest to your device.
Mm-hmm.
This went the other way. But anyway, in the US, in 2017, there were 108 million obese and overweight adults, of which 12 million people were comorbid with type 2 diabetes. And it's not well known, it's not well understood that type 2 diabetes is the actual killer component of obesity. You can be obese and still be kind of somewhat functionally healthy. But once you've got type 2 diabetes, you are on a very hazardous track. And then there's about another million type 2 diabetes sufferers that are not comorbid obese, which results in an addressable market of 119 million patients in the US, where the adoption rate is less than 1% of the surgeries. And nothing else cures obesity, no matter what ads you see on cable channels and so on. Nothing else except surgery cures obesity.
Andrea just wrote and said that your Iranian counterpart doesn't seem to have any patents anywhere.
No, he doesn't.
Oh, you're not surprised by this. I guess I misunderstood the...
No. You know, I don't... First of all, he only created his version of the procedure, which is actually different to my, mechanically different to my surgery. But the end result of his is the same. And he created that around suturing with a needle and thread. And so what he created was a surgical method. What I created was a surgical method which has its own separate self-standing patents, and it's different to Talib's, different enough. And I also created a surgical tool, a device, which has its own self-standing patents. And out of the 9 patents, there's hundreds of claims solidifying the method and the device art. Yeah.
Okay.
So in the US, and I looked this up just the other day, about 300,000 deaths a year is the run rate for obesity and overweight causes. 300,000 people a year in the US die because of obesity. And that doesn't include the years of life lost, YOLL, years of life lost, which is early death and unproductive life. So it's a massive pandemic that, 300,000 deaths potentially is what we hear about with COVID-19 these days. But we've had the obesity death rate running at about the same number year after year after year, and it's just kind of ho-hum. Yeah. But that's the kind of marketplace that I discovered. I had no idea it was there, but it's there. So let's see if I can get the video going.
Right on the bottom there, the play. Yeah, let's see. Okay, it's running. Okay, good. Is there sound or no?
There's no sound with this.
Okay. Where along the product development journey did you create this video?
Quite early on, actually, a functional prototype, which is what you see there. And what it's doing, it's putting a fold into the stomach, which reduces the volume of the stomach without any slicing or dicing or staple lines that can leak.
Tell me about that. Staple lines that can leak.
Yeah. All other procedures, with the exception of the band, all other procedures and or the stomach in one place or another, and where those have to be rejoined, they're rejoined with staplers, and resulting in a line of staples known as a staple line. And unless the surgeon is very careful and very skilled, they can and do leak. And that's a disaster. That's one of a list of failures of the legacy surgeries that is a disaster for the patient. And by disaster, you need to include not only the clinical disaster of having stomach contents leaking into the peritoneum, but you also have to include the weeks and months and even years off of work, years of life lost, and and also the expense, because nowadays, more insurance plans will pay for, very reluctantly, will pay for obesity surgery. But when I last looked about a year or so ago, I don't think more than one or two of them very reluctantly will pay for repairs or redos or reoperations. So the patient has to fork over $20,000 for a reoperation or a redo of some fashion or another. It's an absolute disaster to have a failed obesity surgery, and it happens often. So the next slide shows...
I think you'll need to click on the left on number 6 to advance. Yeah.
Thanks for the coaching.
You bet.
The next slide here will complete the answer to your question, Joe, as to what the difference is between the Talapur procedure and my procedure. If you look on the little...
who just joined us and is listening in the background, Peter's referring to the equivalent, materially equivalent concept?
Yeah, I would call it equivalent, yeah.
That was developed in Iran concurrently, and they both went to apply for their patents at materially the same time. Peter, please continue.
Yes, that's saying at the same time is correct. But I don't know, and I really don't believe that Talapur applied for a patent.
Yeah, well, Andrea said there
Never
is no evidence of
no evidence that he applied for a patent. Yeah.
that he has one today. I mean, they expire.
No, he doesn't. He doesn't. I've never heard that he has a patent. And
Just quickly, Andrea or Stephen, do patents expire after what, 75 years? I know that's music. Is it the same for everything?
I'm not too clear on how long they last, but 17 or 25 years, something like that. Yeah.
Okay.
Patents do expire. But no, he doesn't have a patent, and he doesn't need a patent. Even if a doctor wished to practice this laparoscopic gastriplication in the United States that I have a patent for, a doctor is allowed to patent it as long as he doesn't commercialize it. If he attempts to commercialize it, like taking out an advertisement, he would be infringing my patent. Well, no longer my patent because I sold it. He would be infringing the patents. But a doctor, Talapur, or anybody else can practice a surgery that's patent without the patent, as long as they don't try to commercialize it.
Okay.
Because doctors have divine dispensation to do that.
All right.
So anyway, the Talapur method requires suturing, and as I circled there, it takes an expert, the expert that invented that version. It takes him 72 to 152 minutes to do the suturing. It's a back-breaking, excruciating procedure for the surgeon.
Back-breaking because he's leaned over the patient?
Yes, yeah.
Okay.
And American doctors that have tried this, and at one time several doctors were trying to create a practice around the Talapur method. They just couldn't deal with it. They couldn't deal with because they've never been trained. And they've never been trained in that very, very difficult, intricate suturing.
I trust that you know about them, and they later became Harris converts.
They later became
Harris converts?
No, they would have. I would have liked them to have, but as I'll say further on in the presentation, I was never able to gain traction in my method, and those are the entrepreneurial lessons learned that are the subject of my presentation.
Okay. Well, this is a great setup. I'm finding it very interesting.
Yeah, and thanks for the questions, because I tend to gloss over this stuff too quickly because it's just,
Yeah, no, I get it.
So without your questions, a lot of stuff would be lost. Yeah.
And friends, as you know, you're welcome to type in a message at any time.
So anyway, with the Talapur method, it takes a highly skilled suturing surgeon, and American surgeons are not trained in this level of suturing because they are trained by the linear stapler manufacturers to use linear staples, not sutures. And so with my method, which is functionally a little different, although the end result is the same, it takes about 20 minutes to do the stapling. And believe me, it's easy. This video was done in an animal lab, and the surgeon that came in to do the surgery, she literally didn't know what surgery she was going to do. She said, when she came into the lab, she said, "Hey guys, what is it that we're doing today?" And I showed her, I demonstrated the device to her, showed her how it worked, and she said, "Yeah, I can do that." And she stepped up to the animal subject, and she did this procedure that we're looking at, and it was surgically, functionally, completely functional, with zero instruction other than just explaining to her how to use the tool. It's that easy.
Do you have any video of an actual procedure taking place?
Yeah, I've got the full raw video, but I've abstracted what you see here and what you saw in.
If anyone wants it, you can.
Yeah.
Later. Firstly, I'm curious to know. I mean, this is so afield from what I know. Is my do I have a big cavity here while this operation is taking place, or is this being done laparoscopically somehow?
It's being done laparoscopically. And for those of you who don't know how that kind of procedure works, what they do is they put the patient on their back, and then they insufflate the stomach, the peritoneal cavity, with air. So the stomach is blown up to a balloon.
Mm-hmm.
And then there's special devices that they push in through the skin, which allows access by means of a tool or a mirror or a camera or a vacuum or a whatever, where they put all kinds of tools into that space. But they've got a lot of space to work there.
Yeah, I was trying to figure out how do I get to see these images.
Yeah, there's lots of space for them to work in.
So there's a separate insertion of a camera-like device so I can see what I'm doing, and then your tool.
Yeah.
Thank you.
Yeah, typically I call them bullet holes because that's actually what they look like after a procedure. A patient has 4 or 5. Sometimes, if things go wrong, they need another couple of ports. They just punch them in, and then the patient comes out of there looking like they've been in an Al Capone movie.
Funny. Okay.
But yeah, so anyway, it's an easy 20-minute stapling job that anybody can do. And what it does, and I want to hold my hands up to show, if this is the stomach, the tool, my tool, and Tolopur's sutures put a fold in the stomach and either suture or staple the fold. And so then the stomach, as it's shown in that little hand-drawn sketch there, has the fold inside the stomach space. And so the volume is reduced. And the absolute key to this, to Tolopur's and my procedure, is that there's no incision or excision, no
removal of tissue. So for I don't know if there's such a thing as an average patient, how many staples would be left behind with your procedure? How many would I need to do it properly?
In the range of maybe 20.
Okay. And how, we saw the video where a little bit it's hard for me to kind of imagine, like, what percent of the surface of the stomach are you going to touch? I mean, will there basically be a staple no matter where I don't have a sense of, like, each time you do this, do you lose 5% volume? 3? What?
Well, yeah. If you look back on the screen there to the Tolopur illustration, and if you mentally substitute each one of those sutures with a staple,
yes,
that's what it looks like.
Okay.
And in surgeries, abdominal surgeries and other surgeries, it's quite common for them to leave staples behind. That's not a big deal. They're hypoallergenic.
I would imagine you have to leave the staple behind, right?
Yeah. There's another physiological mechanism that I've also patented, which is the ability of the stomach tissue to adhere to itself. So in other words, where the staple line, where the staples pull the fold of the stomach together, pretty soon, after about 5 days, that surface grows together like a graft.
I get it.
And it cannot be separated by any kind of force. If you hear of someone going into that has to go back into surgery because they have adhesions, abdominal adhesions, what that is the surgeon has been careless, or maybe it was traumatic injury, and the tissue inside the peritoneum area was damaged, and it will grow together, and it will stick together. Normally, it has a layer on it that's lubricant, and everything can slide over everything else inside your stomach. But if it starts sticking together, it jams up and it causes excruciating pain. Well, then, so what they have to do is they have to go in and very carefully, with a scalpel, very carefully separate the pieces of tissue that were not supposed to be stuck together.
Okay.
That's the only way that you can separate the fold of Talipur or Harris. So it can burst open together. But the advantage is, surgically, it can be reversed. And that's a big advantage in a lot of clinical situations. For example, older teenagers, there's a lot of obesity amongst teenagers. Both of these procedures are theoretically reversible. I've never promoted mine as being, easily reversible, but it can be reversed for when the juvenile now is an adult and they've improved their lifestyle, so they don't need this reduced stomach anymore. It can be reversed. The legacy surgeries.
I thought you said that once you staple, I'll oversimplify, and tissues touching tissue, it gets really sticky and can't be separated.
Yes, that is true, but
So then you would go in again and have an anti-Harris tool to unstick it?
yeah.
Did you make the anti-Harris tool too?
No,
Okay.
no, because that's commonly done in abdominal surgery. It's commonly done to have to go in and unstick.
Okay. All right.
Yeah.
Let's move to the next one. So
this shows the three most common legacy surgeries. I don't know if we want to spend a lot of time on this,
I'm
other than to say,
guys, you can tell me if you want to move to the widely applicable lessons that work for any medical device entrepreneur, but personally I wouldn't mind maybe 3 minutes on this, because this is...
Okay, yeah, I don't want to spend a lot of time on this. What I want to say, though, is that these are the three most commonly used legacy surgeries, and they all suffer from the same very high value proposition for surgeons and very, very low value proposition for patients. And
surgeons get rich and patients don't feel better?
The surgeons get rich and the poor get poorer. That is exactly right.
All right.
And they are hazardous without exception. They're very high risk. Without exception, they have very high failure rate. And we're going to look at more of that in the next slide.
So what's happening on the left? Oh, sorry. What's the green? It's a little small for me.
Yeah, that one on the left there is the so-called Roux-NY, otherwise known as RNY. Mm-hmm. And the pink stomach, which is the original stomach, is reduced to the size of a golf ball, which is the green. Mm-hmm. And this was actually the first successful obesity surgery. It's been around since, I think, or at least the 1960s in one form or another. But it's very, very difficult. It requires an expert surgeon. All of these require expert surgeons.
So I'm going to, again, I'm trying to oversimplify, gastric bypass. I'm going to forsake the stomach entirely and put a different mechanism for digestion in there. Is that it?
No. What they do is they cut the stomach away and retain just a small part of the stomach tissue, which they then re-sew.
I see. The pink is what used to be, but when we're done, only the green remains.
Correct.
So basically, we remove 75% of your stomach?
More than 75, maybe 90%.
Wow, okay, that does sound...
And so the failure mode is what you can imagine, is that people get hungry and they try to stuff, because they spent their entire lives eating double hamburgers for lunch, they try to do the same thing with a golf ball sized stomach, and there's a lot of vomiting and a lot of unhappiness, and eventually the golf ball stretches into a baseball size. And because the stomach is trying to save itself. And so then once it's baseball size, the patient starts putting on weight again. And so now they're thinking back to 3 years ago, they paid $50,000 and second mortgage on the house. And now they're putting on weight again, very, very unhappy. And there's no rescue, there's no going back.
Let's talk about the second one.
The second one is the sleeve gastrectomy, where the drawing is a little clearer. You can see where the stomach was cut away.
Okay.
And now the patient has a kind of a banana-shaped stomach.
I see. Same concept, remove 75 to 90% of the stomach tissue?
Yeah, about 80% of the stomach is removed.
Okay. And then this last one removes no stomach, just squeezes it
Now,
together.
the last one is the band. And there's various versions of the gastric band been around. But the band was a failure when it first appeared in Europe. It was known as the Swedish band in, I think, the late 60s or 70s. It had a very high failure rate then. Nothing has changed. Very, very high failure rate, and many, many unhappy patients.
Okay. Please continue.
Yeah. So that's just a summary slide of that. Now, this is what patients really think. This is data put out by the ASMBS, the American Society of Metabolic and Bariatric Surgery.
Okay.
Their estimate of bariatric surgeries, and you can see how the different surgeries are declining. The blue line is the sleeve.
Yeah.
That was the middle one in the previous slide.
Oh, yes, the sleeve, right. You cut away 80%.
The banana-shaped one, they should call it the banana.
Right.
All of them, even that banana, even the blue line is actually regressing, because the number of the increase in obesity patients is increasing faster than the adoption rate of that surgery. So they're all losing ground. But look at that, the gastric band on the right-hand, the table on the right-hand side there, it decreased 59%, 27 over.
Wow. And revisions, what is that?
17 over 18.
What is 9.2% revisions?
Yeah.
I'm sorry, what does that line mean? Revisions, 9.2%.
Yeah, revisions, that 9.2% is that revisions increased 9.2% from 2017 to 2018. So revisions are increasing faster than the surgeries are being done.
Revisions meaning we have to do it again because something went wrong.
Something's gone wrong. The patient's really pissed off. They're vomiting. They have to be redone.
Elizabeth writes, in another life, 1978, as a clinical nutritionist, she worked with Dr. Dudrick in Houston, whose team did many gastric bypass surgeries. And she says it wasn't a great picture. You can bring it on, perhaps.
She said what?
That it wasn't a great picture, and well, now I'll invite her on and she can tell us what that means. Unmute. Elizabeth. So what is the not good picture part?
Well, many of the patients were completely non-compliant after they had this horrendous surgery that took almost days, it seemed like, but many, many hours.
Non-compliance meant still.
Well, I can remember as the nutritionist back in my other life, watching a patient eat gallons of ice cream in their 30 cc stomach pocket and not lose any weight, and then have terrible, terrible complications. So this procedure that Dr. Harris has device
doctor.
looks like a very wonderful way to go in today's world of obesity, obesity surgery. I have a friend, a young woman who I'm mentoring right now, who's 25 years old and just had the procedure and is being very successful. So I've seen this.
Meaning using the Harris procedure?
I believe so. I believe that's what it was in here in
Peter,
San
do you have a sense of what percent of surgeries? I don't have how much ground did you, who bought you? Can you say?
Are you asking me, Joe?
I am. Who bought your patent?
Yeah, I don't want to say who bought it. I'd be happy to.
Have been successful commercializing it?
But let me answer your question as best I can.
Yeah.
I know from monitoring, which I don't do anymore, but for a while I monitored the published papers around obesity, which Elizabeth, I think you'd be familiar with. And so just for my own marketing purposes, I used to keep a running total of the N number of patients that were published. And I got to about 3,000 published cases by the N number, adding the N numbers of the different publications. And so what I say is that to the best of my knowledge, about 3,000 patients worldwide up to that date have been treated by the Talipur, by the fold, the laparoscopic gastroplication.
Oh, yes.
Yeah, so there's about 3,000. There's a very, very solid track record that this procedure works.
Oh, there's no question about that. But this is in 1978, 1980, many, many, many years ago, when people came from all over the world to the Texas Medical Clinic to have this, along with other surgeons, of course, around the world who did this procedure. But it was quite dreadful. And as a nutritionist, we would be supporting them when they needed to be on TPN. So that was a whole other world ago. It was just fascinating. That's all.
Andrea just beamed in.
Thank you.
You have sleuthing skills.
I do. Yeah. So
one question later, she knows the answer of who bought you, I think.
I'm like an IP detective.
Mm-hmm.
That's basically my job. But yeah, so you can see now that the patents are currently assigned to Longevity Surgical. So I assume that's who acquired them.
Neither confirm nor deny that rumor. We'll just measure whether or not he laughs.
Yeah. That's I'm not sure what database you looked at, but the patents have been reassigned. They are no longer assigned to Longevity Surgical.
Okay.
It's interesting. Hey, Peter, you adjusted your camera just enough so that we can't see you. There we go.
Yeah, it says that the Longevity Surgical is owned by Element Global, but yeah, that's the current. So assignees are not they're not acquired, right? So when you require to report when they acquire something, IP in particular. So sometimes the databases are not up to date.
Yeah, I don't know, and I personally don't have the skills to even access the database that you're looking at. All I know is that the assignment documents, I signed the assignment documents, and so as far as I'm concerned, it's a done deal.
Well, we have Andrea. She has the skills to do that.
Actually, Andrea, I'd like to, for any entrepreneur that's listening, any would-be entrepreneur that wants to patent stuff, I would strongly direct them towards someone of your skills to help them with their patent strategies, because it's so incredibly important in the medical device field to have a very, very strong patent strategy, because it can save your business, and it can save you a huge amount of money.
I couldn't have said it any better. Yes, and it doesn't have to be expensive from the beginning. You can make some very smart choices in your strategy of how you're developing your product by having some knowledge of current patents.
And the patents have to be The patents have to be developed hand in hand with as you develop the device, because things change on both sides, and you need to be agile enough to respond to the changes, to make sure that you're developing something that can be patented, and vice versa.
And vice versa, that you're not developing something that's already patented.
Exactly, or you're not developing something where you have no right to practice.
Exactly. Very, very, very good point.
Yeah, and
Do
that.
I have a question? Mr. Levine?
Hey, Peter. So this is all news to me about the laparoscopic space, but your invention seems amazing, like just very nice.
Thank you.
In so many ways. But I wanted to ask, you had on one of your early slides, you talked about you had some experience in lasers and laser surgery.
Yeah.
Can you talk about that?
Yeah. Yeah, my experience in laser surgery was mostly with CO2 laser, and as you might know, I don't know what your background is, but
my background's in imaging, so I want to use them for measurements or analysis. I'm kind of, yeah. What was the use of them in medical?
Oh, okay. So to put it in a thumbnail, lasers come in different wavelengths. Like light, visible light comes in different wavelengths, and the different wavelengths of surgical lasers have different tissue effects. And for example, the CO2 laser with the generation tube, the generating tube is filled with CO2, is very good at ablating tissue. In a single pass, it will ablate about 100 microns of tissue. And so you can use it in a very highly skilled way to reduce the size of a flat lesion, for example, or to make an incision, for example. One of the advantages of a CO2 laser is that the energy actually, instead of tearing at the nerve fibers and irritating the nerve fibers and causing pain, the CO2 laser energy welds the ends of the nerve fibers so that the signal becomes confused, and it does not send a signal of pain to your brain. It sends a kind of a confused hot and cold temperature signal. It's really quite strange to feel. And that has very significant advantages in using a CO2 laser in certain types of surgery. And additionally, it coagulates the blood vessels as it cuts. So you can cut and you can make an incision that doesn't bleed, and also there's no pain, virtually no pain. Other wavelengths, for example, neodymium YAG, have an entirely different tissue effect. There, the tissue penetration is about 6 millimeters, and it can and does cause quite a nasty pain, jolt of pain that the patient cannot ignore. They can't sit still. And there's other wavelengths as well, not to get too deep into that.
Okay, so yeah, that's great. That's what I want to know. Maybe offline, if you have an interest, we're kind of studying the action of light in tissue as well, kind of from the other side. So I know you're kind of looking for things to do. I might have something interesting for you to sink your teeth into. We'll follow up after.
Oh, I would love to do that, even just to talk about it. As you can,
right.
I had to haul on the brake lever there to stop myself talking about it, because it's so interesting in a kind of a nerdy way, you know.
Well, I'll be a good audience for you.
Nerds unite. Now remember, because this happened during a live call, if any money changes hands, I get 50%. Please continue.
Of course, we're well aware.
Okay.
Let's do slide 10. Come on, let's move this presentation along, Harris.
Yeah, okay, so let's keep on trucking. So understanding adoption resistance. What happens is it's like a throttle. We start off with 119 million person addressable market in the States. Very quickly, it's whittled down to a 25 million person validated market. And then we get the throttle of adoption resistance. No ready access by patient, very high prices, no self-pay, seldom reimbursed, and so on. I can go on and on. And the end result is that less than a 1% adoption rate. So I took a look at this from a business point of view, because I knew nothing whatsoever about obesity. I didn't even know anyone that was overweight.
What box did you live in? Come on over one day for dinner.
Yeah, I just was doing my own thing.
All right.
Not
introverted then, I see. Go on.
So from purely a business point of view, I came up with a solution in concept. And that is that you must have a viable surgical model. And we see now that none of the legacy surgeries were viable. A viable business model. Sure in hell, there's no viable business model in the obesity surgery business. And also to identify and address all of the issues that cause adoption resistance, that are really very obvious to anyone that finally opens their eyes like I did and look around and see it was totally plain obvious.
I know that I'm asking you to move along, but two questions going us down. One is, you said that gastric bypass was very lucrative for the healthcare system, not so great for patients. So that sounds like a viable business model.
No, because it wasn't. As you'll see, if we can keep moving, you'll see a couple of slides where it was not lucrative for the healthcare system. It was only lucrative for certain very, very highly skilled surgeons.
Okay. I'll move on to the next question. You've told us repeatedly now you weren't in this space at all. What did you do before this? And what was your aha that said, I'm going to devote my life to obesity surgery?
Answering that question globally, I've spent my career in the medical device business. And in each of the areas where I've worked in or played in or bumped around in, I've come up with ideas and concepts and so on that have really contributed to fundamentally changing or advancing the art. And I just had a creative mind that would respond to inputs. And I know some people are like that. And so immediately before that, I was in the laser business and other businesses. I mean, it doesn't really matter what I was doing, because I've been in diagnostic cardiology, I've been in lasers, I've been in laser cosmetic surgery, and so on. And
all of these as an engineer, an employee of a public or private firm?
Bingo.
And then at one point you said, I'm going to quit my job and make it myself. And that sounds pretty risky. How did the long-suffering Mrs. Harris feel about that?
Well, and the point is that while I was an employee, most of the time, I was fat, dumb, and happy, and I was really happy.
You weren't fat. You said...
No, I wasn't. Right. I was dumb and happy.
Dumb. Go on.
And I was really happy if I could change something, like in diagnostic cardiology, change something and see the technology take off in that direction. And it was my idea, and I did it. And mostly I didn't even get any options, stock options for doing it. But that satisfied my my creative urges, I guess. And well, anyway, so as you pointed out, this obesity idea was the first time that an idea came to me while I was in between non-compete and employee contracts and that kind of thing. And so I jumped on it.
Okay.
So my goals were to reduce adoption resistance. And I met all of these goals. It must be value-based. It must have an excellent value proposition for the patients and the surgeon. And it must be frictionless with low cost of delivery to the marketplace. And I met all of those goals. Value-based. Now here's where I picked it so that it's not beneficial. The legacy systems are not beneficial to the system. An example of a low value to the system is from 2016 to 2013, reoperations increased from 16% to 77% of annual spending on the lap gastric band. Now, how is that a value to the system? That's a damn disaster. And when you look at the disaster, the personal disaster for the patients involved, you can see why it's just not functional. A value proposition for the patient, I define that as satisfaction that the patient receives versus the cost to the patient. Revision and primary bariatric surgeries on average range from 2.5 to 18.4%, costing the patient between $14,000 and $50,000 per revision surgery. So where is the value proposition for that for the patient? It doesn't exist. That's why when the doctor points them at surgery, they run.
Okay.
So, and also, when I looked at two possible business models, I realized that the existing business model was designed and intended by surgeons for surgeons. They had no other vision involved except to satisfy their desire to do surgery and to be highly, highly paid for it. And I'm not being critical of the high pay that they receive for those surgeries, because they are very, very intricate, difficult surgeries, and they have to be highly skilled to be able to do the surgeries. The model that I looked at was to commoditize the surgery so that it could be provided for many patients, and with a goal of it being safe, quick, easy, standardized, urban travels the state of excellence and go through all of that paraphernalia, and then have it so expensive that the healthcare won't pay for it, and they've got no hope of paying the $30,000, $40,000, $50,000 out of their own pockets.
Remind me, LGP is which one?
Oh, laparoscopic gastroapplication. That's
yours.
the Harris, yeah.
Okay.
So,
how old is this slide?
this slide?
Take it. This slide.
What
You're right. Currently, there's only one ready to be commercialized. Do you mean currently as of August 7, 2020?
Right now, yes. There's no other new surgery on the horizon.
Okay, so I recognize that my exposure to this industry and concept is 59 minutes old. So forgive my wife is like, Joey, you hear something, you're really excited, you just want to, why isn't this effing huge, as they say in Brooklyn?
I've asked myself that, and the next few slides will come up with my answers. Someone else might have a different idea.
Okay.
But effing huge is no exaggeration.
Thank you for accommodating me with that.
Wasted resources. Medtronic says that 20 to 40% of global health resources are wasted. Medicare paid $47 million for lap band associated procedures, of which $250 million was for reoperations. What a ripoff. And doctors and the whole system keeps on going, knowing that this is the situation. This is what the revision surgery count looks like. We've already talked about this, so no more time spent here. So the entrepreneurial lessons learned. I wrongly assumed that surgeons and payers would support a quick, easy, commoditized surgery. I was totally wrong about that. Surgeons did not support it, and they don't. They're highly skilled. they're practicing complex legacy surgeries, and they're highly compensated, and they're not going to give that up. And the clinical facilities are ditto on that. In fact, they've organized themselves and branded themselves as centers of excellence. You must come to this center of excellence for your obesity surgery because it's too risky and hazardous, and there's no skilled surgeons at your local urban center, which is the only place you can get to, by the way. I wrongly assumed that the manufacturers of linear staplers used for the closure of legacy surgeries would want the sales revenue increase by selling my device compared to their linear staplers, because they've got no, and I spoke to them more than once. They've got no interest in disturbing the sales and the status quo and the distribution chains of their linear staplers. I wrongly assumed that there would be traction from the typical market drivers in any market, or any segment of the market, of the medical device market, except for obesity, where consumers would be looking for value-based, where they want an excellent value proposition, where they wanted to provide a frictionless service to their customers, their patients, their customers. I wrongly assumed all of that. But the market opportunity, as Joe, as you know, as you pointed out several times, the market opportunity is still there. There's still 300,000 people, patients.
I mean, it sounds as though there were missed opportunities along the way, but as you just said, okay, well, here we are today. So why isn't the patent holder successful in shaking the world by the shoulders and saying, wake up?
Yeah, I don't know. I'm not in close contact with
It can't
them.
be as simple as they didn't hire Joe Hage. I mean, that would be one answer.
Yeah. I truly don't know what their situation is. We did the deal. I'm available to them if they wish me to assist in any way.
Mm-hmm.
But I don't know what they are doing or what their status is.
Okay.
And it's not my place to know.
18. Slide 18.
So, and I have no doubt, and my founding opportunities, we should have done something different. There's a few things I could sit here and say right now where we should have done different, but you know, there's always things that you should have done different. But still, I believe that we were basically crippled, handicapped by making these assumptions that didn't pan out.
Rick, before you share your insightful comment, why don't you mention quickly what you wrote at 8:09 a.m. Pacific time?
Oh, you mean the first comment?
Uh-huh.
I'll actually
read
have
it.
to.
If you don't remember, you said, "What a blast. I just mounted my old sailing charts on my back wall yesterday."
Oh, that is
There's some
phase.
sailing conversation, Peter, that you will be rewarded with Rick's.
Okay.
Back here, you can see New York Harbor. You probably can't identify any of it because it's so tiny. But down here in the lower right of this chart, and these are the actual charts that we used. And I've got some mounted where I can see them. They're right in front of my eyes. But Sandy Hook would be here.
Some video. I'm not seeing that.
Oh,
We'll come back to it. Go ahead and say your insightful thing.
no, it's just in my picture background. We had, as I was in business for myself and we saw our insurance healthcare costs rising, I ran into an electrical engineer that I worked with and I asked him, you know, we were just talking, we were doing a design on his kitchen table actually, and we ended up discussing one thing or the other, and he mentioned that he had just, his wife had just completed a procedure and they paid very little or nothing for it, and I was going naturally interested. I asked him what it was, and he explained to me that there are a variety of health cost share plans available throughout the United States. They were exempt from the usual restrictions in terms of they were allowed to continue to exist and function as businesses. And basically what it looks like is when I had a member of my family had to have a hip replacement. And so we ended up talking to various doctors. We actually were able to select the anterior hip replacement, which has a lower incidence of dislocations, things like that. In the early recovery, we were able to do all kinds of things. And the weird thing was, incomprehensibly, we paid cash for everything, ended up having it cost half the amount, because when you do pay cash, you get all kinds of discounts. And when it came to the gigantic hospital bill, we just arranged to do that on payments for about 3 months until we were able to get the money back from our health share company, and then go ahead and pay the hospital. The hospital was so excited because many of their patients move a year or two after into the payments for their surgeries. So it cost everybody about half the amount or less. It got paid off nearly immediately. The hospital was happy, but the way that it affects, Peter, what you're doing, doctor, is the patient is a whole lot more involved, because when you're actually having to, the weird physical operation of you paying your actual money, even if you're going to get it all back, is a tremendous psychological change that goes on. And so we really went into the selection process. We got on the internet. We researched what the best methods were. If we were doing some kind of surgery like that, we would have found your method. But if we had been on a large healthcare plan, we very well might not have. They may have specified you will do laparoscopic skirt surgery, whatever, to band surgery or whatever. And on the hip replacement, they would have gone ahead and recommended whatever we could get. But we were actually able to select our own doctor. We selected our own hospital. We took care of our own bills, and we had a little extra paperwork because we had to collect the codes that they use to describe the different things that you get from MRIs to the actual surgery. So for us, it was a little more paperwork. And at the end of it, when we got our check and sent it off to the hospital, that was the last thing. We actually ended up having a full hip replacement surgery and paying $0 for it, whereas I'd probably still be paying that off under my own insurance program, sending them a check every month. But the way that it affects, the way that patient-directed plans affect the therapy you get is the surgeon is not your customer anymore. The patient is your customer. And it's a democratization of patient services, getting away from the very, very large plans where they have institutionalized methods. Instead, with the internet and with enough advice, and a doctor visit or two, you're able to quickly determine which method is going to be best for you. And unless you're actually in the emergency room, you make better choices.
This is like Nick Anderson 101 of health economics. Joanne, you had a comment about adoption. You want to share that? Ms. Evans, on mute. I think I unmuted you. Ask to unmute. Unmute. Okay. While we work through those technical difficulties, Mr. Harris, slide 18, please.
Slide 18 is what the likely future is for bariatric surgery. I think that in the future, it's likely that one or more of the pharmaceutical or electrophysiological vagus nerve system modulation methodologies could be made to work, just because it's so simple and appealing and enticing to be able to take a pill to solve obesity, but there's no pill that works. And it's also really appealing to have some kind of an implantable pacemaker type device that modulates some autonomic nervous system within your body to control your weight. And the target for that is the vagus nerve, which does a whole lot of heavy lifting in various subsystems in the body. But none of them work right now, and none of them, as far as I know, in spite of hundreds of millions of dollars being put into it by the biggest companies on the planet, none of them are even close to working. So that's way out in the future. So the legacy surgeries are simply going to keep on chugging along at less than 1% adoption. I do think that the laparoscopic gastroapplication, the Harris system with the enabling tool, it still has its excellent value proposition. It's still proven effective. I'm hoping that somehow some other entity, not me, some other entity will be able to commercialize it. So that's what I see the future looking like in obesity surgery.
Joanne, first, are you unmuted?
I don't know. Can you hear me?
We can.
Ah, good. Okay. Hi, Peter.
Hi, Joanne.
So I'm Joanne. Yeah. I worked as a quality and regulatory director for a short time, although for a laparoscopic company. And my career over the last 25 years has been about updating, fixing quality systems. And one of the things that I've come to learn is that adults who have been doing the same thing for a period of time need to be exposed multiple times, sometimes up to 7 times, before they're willing to even consider adopting new technology or something different. Training, in training systems that I've worked with over the years, just like, albeit that it's inside the organization, you usually have to read the procedure, you perform it, maybe with somebody, in conjunction with somebody, so you're using it right. And then they start using it on their own. And when they've done it on their own a number of times, they're qualified. So and that's technology for learning from Baxter, what I learned. So I know that people don't adopt things easily. So my question for you is, what was your efforts, or what has been your efforts for adoption for adults in changing the mindset of the surgeons? Because you're saying that the surgeons don't want to adopt it. How have you worked to change that mindset?
We were handicapped in any formal effort by an internal issue that we had in not wanting to accept investor input for fear of diluting us two founders.
Mm-hmm.
That I've seen that happen in a startup that I worked with.
Yeah. And so that precluded any kind of formal marketing effort or pre-marketing effort. And so I had discussions with a number of surgeons that really functionally went nowhere because of lack of funding. It cost us a lot of money to develop the patents and to develop the functional prototypes that we had and to do the animal labs. It's an expensive game to self-fund an effort like this. Mm-hmm. And we simply didn't have the money left over for the kind of strategic market addressing plan that I certainly had worked up. And that I was happy to show to potential investors, but unfortunately, at the end of the day, it didn't go anywhere. I do absolutely understand and agree with what you've said, that it takes a number of touches for someone to accept a new technology. I've been in the sales and marketing area for many years, and yeah, it takes up to 6 or 7 touches to convert, unless there's some overriding interest on the part of a prospect. It takes a number of touches to convert them to your device, especially if they are comfortable in what they're doing and they went to medical school on it, and they get weekly visits from the COVIDian or the other linear stapler salesman, telling them that they should stay with the linear stapler program and so on, etc., etc. So, and if you detect some whining in there, you're probably right, but that's the way it was.
Larry, you had a comment that surprised me. Go ahead.
Well, I'm a regulatory ex-FDA guy, and never once did I hear you mention anything about the FDA. And I'm just curious, what is the FDA status on your device?
I mean, doesn't it have to be cleared for it to be?
Oh yeah, and I intentionally didn't include that because that can be quite a long subject for discussion. And
Stop moving your camera, Peter.
Sorry, Joe, go ahead.
Stop moving your camera. It's noisy and it's distracting.
Was the device a 510K device?
Yeah. So okay, so it is a 510K device. There are several very close predicates.
Good.
510, yeah. There's many predicates for reaching, grasping, apposing, and fastening by means of staples. There's just no shortage of predicates. And so I had two very highly experienced regulatory consultants, and both of them gave me opinion letters stating that they believed on the material evidence that I showed them and on their research that our 510K application would be a 90-day application.
And have you submitted it yet?
No, we never did submit it because of various issues relating to funding.
Interesting. Well, the reason I say that is that if you're using it on people in the United States and it doesn't have a 510K, then you have to have an approved investigational device exemption.
Oh, okay. No, yeah. You might have. I might have glossed over that a bit quickly at the beginning, or maybe you didn't catch the beginning of the presentation. No, the Harris version of the laparoscopic gastroapplication cannot be performed without this enabling device. And the enabling device, we only have 2 functional, because as you know, I've sold the patents now, we had 2 functional prototypes. So we only did animal labs. The reason that we didn't have to do any human subjects and demonstrate weight loss is because of the FDA ruling that I think was about in December of 2018, or maybe December 2017, stating that the FDA for 510K certification, for 510K clearance, would accept real-world experience, RWE, and we have up to 3,000 cases being done of gastroapplication demonstrating weight loss and the safety of the procedure because there's no incision, excision, or staple suture lines.
Okay, well, good. I mean, it sounds like you're on the right track there. And but if it hasn't had the 510K clearance in the United States, whoever owns the patents now still has that challenge ahead of them, and it sounds like it's fairly well planned out, but you never know until you try. Without it, you don't have a market in the United States, the owners of the patents don't have a market, I should say.
Well, is that very another entity that I worked with is the engineering and manufacturing company that would take our functional prototypes and turn them into a manufacturable product. They also have their very strong connections, because they're in the business and have been for, I think, 45 years of building surgical tools. They've got very strong connections to the FDA, and they mapped out their own complete roadmap for the FDA clearance, including working, something that I'm very strong on, is sitting down with a case officer sitting across the desk from them and working out jointly with the FDA, working out the roadmap for clearance.
Right.
So all of that has been done and passed over to the new.
Well, that cooperative process in developing your regulatory strategy and talking with the FDA is called the Q-Sub process. And that sounds like what they're using, because you actually get face-to-face with the reviewer and you talk about your development plan and your submit plan, and you get their concurrence on it. So the thing is the company that apparently has the product now, if it's been around for 45 years and they're a surgical instrument company, they probably have in-house regulatory people who know the pathway clearly, and that's good for them. I don't know if you're on some kind of royalty thing or something like that, but I, from the standpoint of what you said, the clinical utility of this, I mean, I had no idea 300,000 people died a year from complications of obesity. And it's the treatments that they've been offered have been obviously not great at all. And your product looks like it could be the one that maybe saves a whole bunch of lives. And with that in mind, I'm hoping that it gets out there and gets adapted, and people who are headed towards an early grave can get fixed and live longer. And that's a good thing. So thank you.
Peter, I know you're
Yeah.
emotionally invested in this thing that you built. You have aspirations that it may be fruitful. You're not the owner anymore. You're not the decision maker anymore. But if you'd like to talk one-on-one about this afterward, it's when I hear a value proposition story as strong as this one that can't get out of its own way, it's frustrating.
Very frustrating. Yeah.
Just from a marketing strategy standpoint, I'm like, what, and I've got all these. So if you feel like playing around with that exercise, we can have some fun. But now it's time for slide 19 of 19. Dun 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 dun. I thought it would be some kind of thank you questions thing, but I wasn't sure. Thank you for doing that. Peter S. stands, what's this? I'm going to go with Stephen.
It stands for Sherwin.
Sherwin. All right. There's a story there.
I used to think so, but
apparently it just rolled off the tongue for your parents, and
yeah, it's an old Brit name from way back in Middle English, I guess, or Middle Ages. It's an ancient name, and somehow it's stuck in part of our family.
Okay. Well, unshare your screen, so it'll just be the two of us as we conclude.
Yeah.
I can stop that.
Thanks for inviting me and facilitating. Much appreciated.
Oh, yeah.
And I will take you up on the one-on-one. Thank you.
All right, you got it. Well, we are out of questions, but I love these. You taught me a lot of new stuff. You've got me thinking, and I think what I heard, if we go straight to the title of today's talk about entrepreneurial lessons, for me, the main takeaway is don't be short-sighted about the need for capital to make this thing work.
Mm-hmm.
Okay. Peter S. Harris, ladies and gentlemen.
Thanks for listening, everybody.
Thank you, Peter. Be well. See you all next week.
Yep.
Okay, bye.